Good afternoon, everybody. Thank you, Scientific Chair and Dr. Amarit, that give me this opportunity to be in this conference. So I'm Dr. Satit from Sirat Hospital, Bangkok, Thailand. So I would like so today I will talk about the think before you embolize, the strategy approach to the visceral and peripheral AVMs. So let me start with the classification of the AVM. So the ISSVA frameworks, they divide the vascular anomaly to the vascular tumor and vascular malformation. And for the vascular malformation, we can divide it into the low flow and high flow. So I will talk about the AVM that's a high flow, that is have the completely treatment strategy, different strategy compared with the low flow. So when we have the diagnosis of the AVM, so the Schrödinger staging can tell us when to treat. So when the patient have the stage 1, so the stage 1, the patient have no symptom. The lesion may be like the cutaneous brush or warm, and maybe we can see just only the AV shunting in the Doppler ultrasound. So in this stage, so we should observe. The observation is the best option for this stage of the patient. And for the stage 2, the lesion will be enlarging, and we can palpate the pulsation and trill and bleed of the lesion. And there is a tortuous vein at the skin of the patient. This is the state that we consider to give the treatment for the patient. If we can treat the patient in this stage, so we can get the cure rate about the 67%. Stage 3 is the destruction state. The patient will have the ulceration, the bleeding, or pain, or necrosis of the tissue, or the osteolytic lesion from the AVM. So this is maybe the late state of the AVM. So if we treat in this stage, the cure rate is about less than 50%. And the last stage is the decompensation. The patient will have the high output cardiac failure and hemodynamic compromise. So this is the indication for the agency intervention for this stage of the AVM. So after we know about the diagnosis and when to treat, and so what the treatment strategy of the AVM. So we have to classify the AVM into the multiple type of the AVM. So we will have the strategy to deal with the AVM in each type. The first one, the type 1 of the YAC type, is the direct AV fistula. So it will have the single arterial feeder and single draining vein. So it's like the direct AV fistula. It's equal to the type 1 of the shoulder type. So in this case, we can use just the coil or the plug to occlude the shunting. The AVM that be the type 1 that we familiar is the pulmonary AVM. The cure rate is about 100%. So for the type 2 is the classic NIDAS. So we have the multiple feeder, multiple small feeder, multiple draining vein, and we have the small NIDAS. So it's equal to the type 3 of the show type. So in this type, so we can use the intra-arterial, endovascular, transarterial, or direct puncture to the lesion. You can use the liquid embolic material such as the ethanol or the other like glue or the EVOH, or we can use coil to embolize the vein, the outflow vein. And the type 3 is the aneurysmal vein wall is the NIDAS. So the lesion have like the single draining vein with the multiple NIDAS along the wall of the vein. So this we can use the coil embolization at the outflow vein, so it can be cured. And the last one is the type 4 of the YAC type, is the infiltrative type. So in this case, the the patient will have no discrete nidus, so it is have infiltrative lesion along the soft tissue or the bone. So this type is the quite aggressive type, so we cannot, the cure rate is just only 40%, so we can use like liquid embolic material with the direct puncture, and we have to use multi-stage to the embolization, and most of the case we cannot cure the lesion, so we just do when the patient have symptom to relieve their symptom. So this diagram show the treatment option of the AVM. So we can use the transarterial endovascular with the balloon occlusion and inject the liquid embolic material, or we can use the venous outflow balloon occlusion, or we use the direct sac puncture, direct nidus puncture with the liquid embolic material, or in some cases that have the big shunt, so we can use the arterial, the coil embolization at the arterial site at the shunt. And also we can use like the super selective embolization with liquid embolic material, the retrograde balloon assist embolization from the vein, or we can block the venous outflow vein with the coil. And sometimes we can use the blood pressure cuff to reduce the flow when we inject the liquid embolic material, to help the liquid embolic material go further and fill all of the nidus. So I will start with the pulmonary AVM. This is the YAC type 1. So normally it have the one arterial feeder and direction to the one feeding vein. So when we do the embolization, we can do the embolization at the feeder, very close to the nidus, or we can embolization at the venous sac also. So if we can embolization at the venous sac, so the occlusion rate is higher, 94%, but we have to use the more embolic material, more cost, more procedure time, and radiation dose is much higher. So this is the first case, the pulmonary AVM, the YAC type 1. So you can see that this is the left pulmonary artery selection, and you can see that there's a pulmonary AVM here. This is a small AVM, so we try to select into the shunt, and at that time we try to go further to the shunt and put the impulsive vascular plug here. This is the impulsive vascular plug type 4. And this is after embolization, but you can see that there's another branch that go into the shunt like this. So that we don't see this artery before we embolization, because of we block the main flow of the AVM, and then the smaller artery come out. So if we don't see this, it will like the recurrent AVM after that. So finally we saw this, so we have to super select into that vessel and do the coil embolization for this one. This is a renal AVM, the Kaunas type. It's also the YAC type 1, so it have the direction from the artery, the single artery to the vein. But you can see that there's a enlarge of the draining vein because of the very high flow of the AV fistula. So at that time I put the guiding catheter into that shunt. So you can see that the artery is in here. This is a fistula, and this is a dilated venous pouch. At that time I put the impulsive vascular plug type 2 to close the shunt, but it still have some flow into the vein, so I put some coil after that. So this is after embolization. So you can see that the flow to the kidney is much better. So the kidney function is better after we do embolization, and the blood return to the heart is less, so the patient, the cardiac function of the patient is better. Renal AVM can have the cirrhoid type. The cirrhoid type is the type 2, YAC type 2 AVM. So this is the AVM on the right kidney. So this is after we select into the right renal artery, and you can see that there are multiple arterial feeder to the AVM, and there's the nidus and the draining vein to the renal vein. So this is after super selection into the AVM. So you can see that there are multiple arterial feeder here, and in this case we use the glue. So we inject the glue here to occlude all of the arterial feeder and nidus. This is after embolization. So you can see that the AVM is gone, and the renal enhancement is much better. So the next case is the pelvic AVM. Normally it show like the YAC type 2B. So you see that there's a multiple arterial feeder, the nidus, and also the dilated draining vein here. So in this case, we try to super select into the internal iliac artery and see that there are multiple arterial feeder to the nidus. So in this case, I super select into each vessel. So there are around 8 arterial feeder, and I do super selection and use the glue embolization for this AVM. And this is after embolization, so you can see that the AVM has gone. This is a CT scan after the embolization. This is another case that the pelvic AVM also have the multiple arterial feeder and also the dilated with draining vein. In that case, because of there are multiple arterial feeder that we cannot select into that artery. So at that time, I use the direct sac puncture to the venous sac. This is a needle by ultrasound guidance, and after we puncture into that venous sac, so we put the coil inside. This is after coil embolization, so I inject the contrast and see that there's a contrast reflux back into the artery because we already occlude the outflow vein. After that, we inject the glue at the vein and let it reflux back into all of the nidus around here. So you don't need to select the artery, but you can use the glue back from the vein, and this is a complete embolization of this pelvic AVM. This is another case of peripheral AVM. This is a YAC type 3. So there is the multiple arterial feeder and the draining vein here. This case, after angiogram, so you can see that there are multiple arterial feeder and the draining veins like this. So at that time, at first, I tried to direct sac puncture into the venous draining and do coil embolization for that. And after coil embolization, I inject some glue inside to eject the glue and let it go back to the nidus. And this is during glue embolization, so you can see that the glue reflux back into the arterial feeder. But after embolization, so this is the angiogram after that. So you can see that there's a residual AVM at the inferior part. So I do the second session. So I also use the direct puncture and also the venous approach to do the coil embolization, and then I inject the glue there. I should skip this. I will show you this one. This is the fourth session. I will show this. This is after the 3-time embolizations, and you can see that there's the residual AVM, and in this picture you can see that there's multiple nidus along the vein wall. That you can see that there's a nidus along the vein wall. So in this case, we should do embolization along the vein, the segment of that vein. So in this case, I direct injection of the glue to the vein to close all of the segment of that vein. This is another part that I do direct puncture and do the glue embolization at that part. This is during glue injection. So this is after. Oh, why it's not play? Oh, the video is not. So this is after embolization, so we can get the curative. Oh, for this patient, it's not work. So I should skip this. This is a type of the peripheral AVM, that the YAC type 4, that infiltrative lesion. So I do multiple embolization with the transarterial treatment with the glue embolization, and also do the direct puncture into the sac, into the lesion in the intraosseous lesion, and do the core embolization and glue embolization for that. And also, it's okay, it's not work. And also do the glue embolization by direct sac puncture. So because of the AVM cannot be treated solo, so you have to have the core, the MDT team, the vascular surgeon, the radiologist, also the geneticist, and sometimes you need the dermatologist, cardiologist, orthopedist, psychiatrist, or even the interventional neuroradiologist to help you to treat the patient and give the good outcome for the patient. So this is the last slide. So I have to summarize that. The first one is you have to classify before treatment. So the YAC and Shodo classification is one of the treatment strategy. Don't just after your classification, so you can manage the lesion, how the technique, what's the embolization material that you will use, and arbitrate the nidus. This is the goal of the embolization of the AVM, so you should attack into the nidus, not just the feeder. And no, you do not embolization, not embolize organ like the hepatic AVM in HST, so it's a non-touch lesion, so you don't embolization the hepatic AVM. And you have to counsel the patient honestly about the outcome. So in some case, we cannot do the curative aim for the patient, so we have to talk about the outcome of the patient, and we can have the multiple sessions. Also, we can do for just only the relief symptom for the patient. And the last one is think about the molecular and genetic. It's now standard, so especially for the type 4 AVM. Thank you.